Welcome back. We have such a really great presentation today that we're excited to get started with. So we won't delay any further. If you're just joining, please put your name and your institution in the chat. This is the second team webinar for the Maternal Equity Bundle from Penquin as we're optimizing racial equity across the state of Massachusetts. We have a special guest speaker who is a very good partner and friend to Penquin as well, Renee Byfield, who's been the leader and supporter of our Speak Up Against Racism training that we've offered to the state. So we'll get started with a little housekeeping, and then we'll review some of the data from the structure measures, and then we'll, without further ado, to have Renee join us to do some QI teaching, particularly around forming your racial equity teams, or your equity focused teams, I should say. We'll go to the next slide. So welcome again. If you're just joining, please put your name and institution in the chat. How we do these webinars, please keep yourself muted when you're not speaking, though feel free to type in your questions to the chat between Kaylee, Claire, and I. We're always watching for the questions. These sessions are always recorded and you can see them posted. CME is rewarded for attending these webinars as well. And so you'll see the questions for CME after watching any videos. Go to the next slide. So as usual, we start off with a welcome. We talk about our hospital data, and then we'll go into our speaker. Our speaker also has a number of slides on QI strategy. So we'll do some Q&A afterwards and allow for teams to share and let us know how they're doing. And then we'll have some wrap up and announcements. Let's go to the next slide. So here is our work group, our Penquin Maternal Equity Bundle work group. I want to say thank you to everybody whose faces you see on this work group. Also, thank you to the faces you don't see on this page that are also very active and involved in the work that we do. Thank you to all of the teams. We have 16 teams, yay, part of this webinar and part of this particular bundle. So we'll go to the next slide and see the spread of these 16 teams across the state. So a good representation across Massachusetts, a little bit less on the west side of the state, but still, if you have friends or other groups out that you think may be interested or would benefit from engagement in this bundle, don't hesitate to share and send them to the webpage. We'll go to the next slide. So just as a reminder, your bundle information, the measure survey that goes out to each team that's participating, which includes your structure and process measures, those come to you from the Betsy Lehman Center. Those are due to be completed by your either RN or MD champion or CNM champion or your QI data staff. Those are submitted by the 10th of every month. Just a reminder to submit those by the 10th of every month. For any new teams joining, if you have not joined and are interested in joining, you'll get in touch with Kaylee Vitek, our program manager, who will help you with the registration and also signing of the memorandum of understanding with the Betsy Lehman Center so you can submit data. Go to the next slide. So if you have not submitted data for September and October, please reach out to Kaylee and Claire because they can help with reopening the survey. And if you haven't, that's okay. This is a new bundle. This is new work. This is work many of us have not done before. We completely expect that there's going to be folks who are, dipping their toe in the water and then figuring it out and then wanting to come back in. So we welcome you at any time, and we're here to help at any time. All right, let's go to the next slide. And for any of those of you who have just joined, you could put your name and institution into the chat. That would be fantastic. We've heard you. We wanted to make sure that folks knew that for the people who have let us know that the data visualization has not been friendly to their eyes, we have updated to a colorblind friendly data visualization. And we're still making some tweaks and edits to the data visualization just so that we can help to ensure that when we look at the data, it tells the story right away that we want to have told. All right, let's go to the next slide. All right, so the data review. We'll review our structure measures again, and we'll come back to the process measures in a future webinar, but the process measures will be posted alongside the other measures in the end of this webinar along the slide deck. The structure measures, as you recall, there are 4. If you go to the next slide, the first structure measure asks the question about your formal equity team based in obstetrics and reproductive health. So this shows 2 months worth of data. In the month of September, we had 11 hospital teams respond of our 16, and in October, we had 8. So again, we know that we have 16 teams registered. So if you have not been able to answer any of these questions or respond to these surveys, don't hesitate to reach out. We're happy to reopen the survey and help you bring in your information. We just want to share that many of us are at the beginning of this work, that of the 11 hospitals in September that have responded, we had, oh goodness, it was 5 teams that had a formal equity team, whereas we had in October, of those 8, there were 3. Now, when we say, okay, we have a formal equity team, if you go to the next slide, we're wondering to what degree is that equity team diverse in terms of having a diversity of roles, a diversity of race, ethnicity, a diversity in terms of bringing in community members to be a part of those conversations. And all of our equity teams that have responded that they have one. So the colors that you're looking at here are just among those who have equity teams. So for the 5 in September and the 3 in October, what you're seeing is that everybody is at different stages and at different places as they engage in making sure that they're diverse, their equity teams are diverse with nursing in terms of diversity of roles, physicians, social workers, trainees, et cetera. And then diversity of race, ethnicity, diversity of language could be another component. And then to have a community member. Everyone is still working on adding a community member to their diversity teams. So we'll go to the next slide. The second structure question asks around obstetric equity goals. So we asked the question, does your hospital have equity goals that you've created and made available to or communicated or visually displayed for your hospital teams? And so of the hospitals that reported, 4 of 11 reporting hospitals in September and 3 of 8 have an anti-racism statement. We found that to be pretty interesting. I'll also add, I found it interesting that Renee Byfield, who's on the call, we had created a webinar with in partnership with PQI on anti-racism statements. So we have a structure for folks to utilize, to think through. And with that, what we've also seen is that some of the anti-racism statements that are online have come down. So I know people are revamping them. Some people are changing directions and how they want to communicate their values to the community. I think it's really important for us to feel comfortable and confident around how we've created an anti-racism statement and how we're going to display that. I know in our hospital here, we've created an anti-racism statement and working on how we're going to display that as well. What's nice about the exercise is simply the ability to work together to communicate values around what you want for your team, because it's important for your team to have a sense of health, wellness in terms of delivering care, and then also what we want for our community that we're serving. All right, we'll go to the next slide. So this is a third of the structure measures. The third structure measure asks, do we collect information and all of these different identifiers so that we can begin to think about how to disaggregate or stratify data by different places that you can find inequities, whether that be by differing levels of ability, by race, ethnicity, by gender identity, by language, by sexual orientation. And we all know, I think many of us have seen our hospital systems are growing in the ability to collect that information in the electronic health records in terms of self-report of these identifiers. Of the 8 hospitals who responded in October, most collect language and race, but many of all the hospitals are still working on collecting the other identifiers. So many are not fully in place, but many are as well. So I think the hospital systems in general are doing well with that, because as we've said, as we've done our SMM review, and you can go to the next slide, Kaylee, as we've done our SMM review with teams, we've found that some hospital teams don't have a disparity in terms of race, ethnicity, but they may have a disparity in terms of language. They may have a disparity in terms of geography and where their patients are coming from, rural patients getting to care and having care experiences that are different from others. So it's important for us to think about how to disaggregate and stratify that data. And that gets to the 4th structure measure. And so we'll stop with the data review after this one. But among those hospitals that reported in October, 3 of the 8 stratified by race, ethnicity when they're looking at their data. And we've done that for the teams, again, when we've brought the SMM data forward. However, the majority are still working on how to stratify by those other identifiers. And that becomes really important as we think about all of our obstetrical focused projects within our institutions and on our L&Ds, making sure that we have the ability to disaggregate and stratify that data by what matters to the patient populations that we're serving. All right, we'll go to the next slide. So for data submitted for October, 5 of the 8 hospitals currently have a PREMS. that's implemented. So here's our fifth structure measure question. Sorry, I kept saying 4. The PREMS is the patient reported experience measure. That's important to say again, patient reported experience measure, not PROM, which is the patient reported outcome measure. This is their experiences. So we really find it very important to understand and learn, what do patients experience when they come to our hospital systems. And so of the hospitals that were surveyed, 5 of the 8 currently have a PREM in place, which is fantastic. We have a number of hospitals working with our partners that are strong partners or Pinquin. We have the same value systems, and that is the Team Birth group that's with Ariadne Labs and the Team Birth hospitals. There are 10 of the 10 Team Birth hospitals participating in that work while we are undergoing and implementing this equity bundle. And with that, there is a PREM associated with working with Team Birth. And that's important because those hospitals will also be able to say they have a PREM associated. And the PREM is really only as good as what that information tells us about whether or not patients feel seen, heard, and valued, and a part of their decision-making and a part of their team during their birth and care. If we go to the next slide, we have some information from some of the hospitals of what they've considered to be their PREM. Many have said that they have HCAPs in place, which is from the Center for Medicare and Medicaid Services. Others have NRC real-time survey and HCAPs. And then another has Press Ganey likelihood to recommend. So again, those are helpful. In addition to that, others in October added that they're on the journey to including the PREMs for Team Birth. With that, again, we want to just know from our patients how they're experiencing obstetrical care, whether or not they're feeling that their choices they've been a part of the choices, that their choices have been respected, that they feel seen, heard, and valued. So it's really important to think about what your practical patient report experience measure is that you have for your system. All right, so with that, we'll go to the next slide. And we'll pause for a moment and just take a poll. We know many people have been engaged and want to do this work. We've done coaching calls with some hospital teams. If you're interested in a coaching call, don't hesitate to reach out to us and ask. What we do want to know is what you're working on. Which structure measures are you working to complete presently? Are you working on your formal equity team? So we know that there are folks that, that is a step in of itself to get the leadership buy-in and support to create that. Are you working on your equity goals, such as our anti-racism statement or change concepts, or your SMARTY goal or AIM statement? Are you working on ensuring that you have the ability to collect demographic information and stratify by that information with your all of your various projects? And then additionally, are you working on PREMs? Are you working on patient report experience measures and adopting and finding one that's practical and implementing it in a way where that information can help guide how things are going for you on your labor units? Fantastic. We're getting around 34% have participated. So for those of you who have the ability to answer the poll, we'll keep it open for just a few more moments. I'll point out that our project coordinator, Claire Conkling, has put in the chat. If you missed it, check out the webinar from last month focusing on PREMs that was presented by our Team Birth colleagues. And there's a password there for that particular webinar, and that's MAEQT 2022. Terrific. We're at about half. And what we're finding is it's like some thirds here. About a third of folks are working on developing their formal equity team. 8 of 31 said they're working on anti-racism statement, change concepts, or a SMARTY goal. 10 of 31 are working on data collection, and then a few others are working on PREMs, but not as many. Thanks for answering that. And thanks for participating and letting us know where you are. Also, let us know how we can be most helpful. Like these webinars, if you'll notice, each webinar is tuned into a structure measure, and then later on, you'll notice the webinars are focused in on each of the process measures. So we'll go to the next slide. Were you guys able to see the results? Did it share? Good. We have a driver diagram for you guys too as well. If others have not put together a driver diagram, or they're thinking about their equity goals and their change concepts, we have one here. We will have it posted on our website for you to use. You can use that and tweak it. Everything we have for you is for you to take and adapt to what fits your environment, what fits your hospital system. If you notice the nice arrows to the top right corner, structure measure 1, create your equity team to lead your projects, especially around this particular equity implementation. So if you go to the next slide, you'll hear more about that from Renee Byfield as she gets started. And without further ado, I'd love to introduce our partner, Renee Byfield, who leads the Speak Up Against Racism program for the Institute for Perinatal Quality Improvement. She has been a nationally known quality improvement expert across the country. She's worked on implicit bias education. She's worked on quality improvement under the guise of AWAN, as well as within her clinical institutions, and now is in the Georgia area. Without further ado, I want to turn this over to Renee Byfield, who talked to us about QI strategies to achieve birth equity. Renee.
Thank you. Can everybody hear me?
Yes, we can.
That's wonderful. So glad to be here, and so glad to partner with Massachusetts Penguin. And fortunately enough, we're going to be continuing our partnership. So I will be talking about quality improvement strategies to achieve birth equity today. And again, I am the program director at the Institute for Perinatal Quality Improvement and the Speak Up program. And I recognize a lot of you in the audience, which is wonderful. I have nothing to disclose, and these slides are owned by PQI with all rights reserved. Today, I'm going to be discussing the importance of forming a department equity committee, describing how quality improvement tools are used to create and accomplish equity goals. And Massachusetts, we are 407 strong in terms of Speak Up champions. That's 31% of our 1,200. And I know this number, I wake up thinking of this number, I go to sleep thinking of this number. We're doing really great across the country. We have 1,282 champions across the country. So, and Massachusetts plays a big part in that number. We have upcoming champion courses. The next one is December 7th and 14th. And then in February 2023 and May 2023, we will have others. So stay tuned for the dates. We also will have an ambassador course November 1st in 2023. So I want to center us by thinking about what is our overarching goal, which is to achieve birth equity. Now, the definition of birth equity is the assurance of the conditions of optimal births for all people with a willingness to address racial and social inequities in a sustained effort. And I emphasize the term sustained effort because we have to be very strategic and purposeful when we're trying to have and sustain gains for our work. So, quality improvement is a framework we use to systematically improve the ways care is delivered to patients. And quality improvement can be a crucial means by which to achieve equity in health and health care. So in other words, quality and equity go hand in hand. Quality improvement interventions are health equity interventions because every healthcare process change has the potential to improve, maintain, or worsen an underlying disparity. So health equity considerations should be fully integrated into every quality improvement intervention from the onset. In essence, there is no quality without equity. So it's quality improvement is like building a house, right? This is our foundation. These are the foundational questions that we ask ourselves as we're launching these efforts. Number one, what is the problem? Number two, what is causing the problem? Number three, what is the goal? And what steps will we take to reach that goal? We first have to identify equity goals, and our goals should be set using an equity lens. They should be more than just SMART goals, they should be SMARTY goals. And if you remember the SMART part of it, they should be specific, measurable, attainable, realistic, and timely. But I want to focus on the IE portion of that. So when we talk about being inclusive, it brings traditionally marginalized people, particularly those most impacted by the processes, activities, and decision and policy making in a way that shares power. And that means that they get a stake in the decision making. The people you include in the process of making and accomplishing your goal are at the table because they will influence the outcomes in a meaningful way. When people and communities, particularly those impacted by a goal, are included in a way that shares power, the process decreases disparities and leads to more equitable outcomes. And that's really our goal. In terms of the E part of it, which is equitable, that includes an element of fairness or justice that seeks to address systemic injustice, inequity, or oppression. So if you look at my slide, I have a SMART goal, which reads, build an equity committee of 20 key leaders and staff by January 2023, right? Sounds pretty strong. But once we turn it into a SMARTY goal, it reads, build an equity committee of 20 key clinical and community leaders and staff by January 2023, with at least 5 to 8 people of color recruited first to help shape the committee. And as a reminder, and Dr. Meadows shared this already, these are the birth equity goals that PIN, Quinn, and PQI developed webinars for. And what we did was we gave you the blueprint for how to accomplish these goals. So just as a reminder, they are recorded and on the PQI website. It can be accessed at www.perinatalqi.org. And the titles of them are creating an anti-racist statement, improving data collection and review by race and ethnicity, performing team and family debriefs with a racial equity lens, and ensuring maternal care standards are met for birth equity. So effective change leaders must have practical knowledge of the change process and be equipped with tools to develop a change management strategy. The MAP-IT framework is a quality improvement process model that can be used to guide teams through change and accomplishing goals. To improve, each facility should ideally develop a structured map of how the desired change in practice will occur locally. The MAP-IT cycle can facilitate this process. The acronym MAP-IT has 5 steps of success. They include M, mobilize, and for the purpose of Massachusetts, I customized this MAP-IT to reflect the work being done. So assemble the equity committee action team, explain why change is needed, assess what is going on, review data, and identify quality improvement opportunities. P, plan strategy, develop the action plan, set goals and metrics. And I, implement the action plan, adapt changes to organizational context, identify and mitigate with barriers, and identify and cultivate facilitators. And then T, track, meaning monitor strategies and track your progress. Of course, with these type of process improvement models, QI is a continuous activity. So during implementation, your team should perform small tests of change to learn, then adjust. As you implement changes, there will always be issues to address and challenges to manage. Things are never perfect. You can learn from each experience, then use those lessons to shift strategies, try new interventions as needed, so you are continually moving incrementally towards accomplishing improvement goals. So now we're going to focus on step 1, mobilize. So begin by mobilizing key individuals and departments into an action team. Form an equity work group that includes a nurse lead, physician lead, perinatal leadership. You can include students, marketing, risk management. I would even include the patient registrar, community leaders as well. This work group should be diverse. There should be more than one person of color on the team, giving different perspectives and viewpoints, for example. You want to select project leaders, seize the opportunity to have interdepartmental collaboration. For example, pull in transfusion medicine, anesthesia, to coordinate, implement, and monitor change. And when selecting the project leaders, consider the stakeholders, supporters, facilitators, experts, and the departments impacted by and needed to accomplish these practice changes. You also want to recruit your cheerleaders, right? They're called our QI champions. This interdisciplinary team of QI champions will be committed to supporting the change and facilitating buy-in. When selecting champions, consider the subject matter experts and required skill mix needed to accomplish and sustain these changes. So an important question in this piece of recruitment, right? A powerful guiding group has two characteristics. First of all, it is made up of the right people that are able to demonstrate effective teamwork. So I'll ask you, how do you build a team of the right people? What is that perfect sweet spot? The right people are those individuals who possess appropriate skills. They possess relevant knowledge. They're content experts, knowledgeable about processes and about what's happening outside the enterprise. In other words, what's happening in the global community of OB, for example. That's essential in creating the vision. They possess leadership capacity. Some should have formal authority and the managerial skills associated with planning, organizing, and control. This is needed to create short-term wins. They should have organizational credibility, recognized as leaders, respected, possibly have connections, influence, and sometimes stature within the organization. Ideally, have connections to manage organizational change. This is essential for creating a communication of the vision. And they should also have valid information about the internal workings of the facility. This is essential for removing barriers that disempower people from acting on the vision. You want to engage the right people in the community as well. Having the voice of the consumer is invaluable. It can lead decision-making to ensure that quality improvement enhances health equity. And note, the right people aren't necessarily those that are in senior management. All right, consider all the considerations that I shared with you. And what will they do? In this step, they'll create the vision, the mission, the overall project timeline, and stakeholders will be identified, allies will be identified, specific roles and responsibilities will be assigned. So now we're going to talk about the assess portion of the MAP-IT. Here we will review data and identify quality improvement opportunities. So you don't want to be this guy in the center, right? It's not denial. I'm just very selective about the reality I accept. Okay, we don't want to be that person. Quality improvement steps include first understanding existing disparities. Data is the cornerstone of quality improvement. Data may reveal to us what we do not want to admit or see. However, we should not be afraid to look at or deny our data. Data helps us know what improvements are needed, and data will help us uncover disparities that we may not currently be aware of. So in order to do this, once we have and believe our data, you are well positioned to assess cause and effect by creating a fishbone, also known as an Ishikawa diagram. This is done during the pre-planning phase. A cause and effect diagram has a variety of benefits. First of all, it helps the team understand that there are many causes that contribute to an effect. It graphically displays the relationship of the causes to the effect and to each other. It helps to identify areas of improvement. In order to develop a fishbone, you want to, first of all, establish who is going to be the facilitator. And what I've done in the past with this is determine who will be assigned the main causes or classifications. You want to define the problem, then generate main causes of the problem. So in essence, what I would do, frankly, is once that is established, I would assign a rib to either a group of people, or if there's connections between two ribs, I would have them assigned two ribs of this diagram. Now, in this example, the major categories of ribs that I'm referring to are materials, supplies, what you use, the process, which is the activities, the people, they can be staff or anyone, everyone who's involved, the customer and patient, the environment, equipment, and measurement. You want to brainstorm ideas related to the main causes. I know it seems very intimidating. In fact, I remember the first time that I had to do one, I ran away like it was the plague. It was very intimidating, but having a group of people thinking together through the process really can be helpful. You want to also interpret results from the diagram. Identify any causes or ideas where there is immediate action that can be taken. This can feed your quick wins or your short wins to really inspire people to keep on going. And then the next steps, you want a brainstorm session. You want to have a brainstorm session in terms of looking at the diagram results. Discuss successful and unsuccessful strategies that have been implemented in the past, identify new strategies, and establish network-wide goals for addressing the issue. This Ishikawa diagram is from PQI, and if you see the main causes or classifications are societal factors and community factors, relationship, and individual. So really in an Ishikawa diagram, the factors are going to be unique to your situation or what you're facing in your facility. However, they can be very similar in that you all have a shared goal in this equity work. So now we're going to address the plan. Developing action plan, setting goals, and also determining the metrics. As we create a plan, the driver diagram provides the roadmap, okay? Hence the term driver diagram. The basic anatomy of this is the aim, and that should be a clear articulated goal or objective, the desired outcome, and good aims answer the question, how much improvement, to what, for whom, by, when? The key primary drivers are the high-level elements or factors to change to achieve the aim, and these are interventions you test for each primary driver. The secondary drivers are changes to test in order to learn if they have a positive, negative, neutral impact on the system. And they should be dated. These are living documents and updated as the team learns what changes work and what don't work. This is the Massachusetts driver that Dr. Metters showed earlier. And we're going to address one of the top secondary drivers further on in the slides. I'm not going to go in detail in this. She has suggested that you have access to this and can use it and tweak it as you need in terms of making it fit into your local, what your local needs are. Process mapping is also very helpful. It shows a graphic representation with illustrative descriptions of how something gets done. It helps the participants to visualize the details of the process closely and guides decision making. One can identify the major areas of strengths and weaknesses in the existing process, such that contribution of individual steps in the process. Further, it helps to reduce the cycle times and defects in the process and enhances its productivity. A good process map should illustrate the flow of the work and the interaction within the organization, and the ideal process map should contain proper detail with respect to multiple paths, decisions, and rework loops. As a nurse manager at Kaiser, I had to launch a new procedure, for them at least, called a percutaneous tibial nerve stimulation, PTNS. And on your right, this is the process map that we created for that process. And I can't tell you how many times we had to go back to the drawing board because we'd never done this process before. All right, so we had a lot of insights from our partners, but we had to make it work for our organization, our facility, and we had to tweak it quite often to get it right. And even after we launched PTNS, we had to tweak it yet again to get it perfect because we learned things as we actually did the process. So in your case here, when we're talking about the secondary drivers, and you see a screenshot of the secondary drivers that is on your driver diagram, the process map provides us opportunities for learning. Again, I gave you the example with urogynecology where we drew that process map so that we could go through the process together, and it was a visual for us. And we know that visual learning tools are much easier than just having it we're kind of figuring it out and talking to each other. So the opportunities here for a process map is when you're providing staff education and training on how to ask demographic intake questions, right? Another potential process map can be developed when you're ensuring patients understand understand why race, ethnicity, and language data are being collected. And this is for staff. The process map would be for staff, and also to educate staff on how to access interpreter services. So again, talking about plan, deciding what your metrics are is crucial. You have metrics that are already on your driver diagram, but just in short, I want to just revisit just the definitions of structure, process, outcome, because they do serve as confusing sometimes. So the definition of a structure are those components within the system, in this case, the healthcare system, that are constraining or affecting the processes or behaviors of individuals or groups interacting within the system. And the examples are policies and procedures, educational offerings. And the process measures are the specific behaviors of perinatal health professionals or how you take care of patients. And then the outcome measures are the result of structures. For example, morbidity and mortality rates, SMM data by race, ethnicity, and language. So now let's go back and look at the maternal equity bundle and your measures. So again, under structure measures, you have equity team, real data dashboard, practical prems, community engagement. Under your process measures, you have the percentage of staff trained, having the bias training and respectful care training. Under process measures, you have perinatal care standards met by real data. And then the outcome measures are your PREMS respectful care index and SMMM rates by real. So we've talked about a lot in terms of how to use the MAP-IT, and we're not going to get into the implementation and tracking piece. But this is a time to pause and think about those questions that are crucial to moving forward with your equity work and using QI as a tool. This is a list that I've kept with every project, and I go to it very often to check off to see if I'm staying on course. So what areas do you want to focus on for improvement? We've got that checked off. We've kind of figured that out as a team. What are our goals? And that's not to say that that our goals can't change as we learn more, right? What initiatives will you implement? Who will be affected and how? Who can lead the initiative? And this may change as persons leave the organization or get into new roles, right? What resources will be needed? What are potential facilitators? And frankly, how can we leverage and spread those facilitators, right, to others? And what are possible barriers and how can they be overcome? How will we measure progress and success? Are our metrics correct? Are we on point with where we need to be? Do we need to add any others? And what is the timeline? Record your planned start and end dates for the action. And then how will you share your action plan? It's important to have transparency and sharing progress. In any quality improvement project I've been in, that is crucial to keep people inspired, because when you're visible and you're showing what is happening and what they've participated in, they feel inspired to continue on. And it really keeps the momentum going. And especially when you're having, you're in healthcare, there are many competing priorities. So thank you so much for listening. Just want to remind you that we are going to have a 28-day challenge, and that is going to be launched in February 1st and during Black History Month. 28 days for a reason. You will receive daily email reminders with a link with a reflection, a learning activity, and action for each day. So please do sign up. It's open registration at this point. And also too, this is our action pathway. Just a reminder, this is accessible on the website as well, and many of you are champions and have this, so I won't go in detail into this. Again, our next Speak Up is on December 7th and 14th, and we'll have more in the year 2023. And our ambassador course will be November 1st, 2023. You will have access to our CME modules, why everyone must speak up, pledging to speak up, and how to speak up against racism in perinatal care. We also launched intermittent auscultation simulation-based education version 2 on May 20th. So that can be accessed on the website as well. So thank you for listening, and I guess we're open for questions.
Thank you, Renee. That was fantastic. Please, others, put your questions in the chat, and if you'd like to unmute, I see one raised hand. Let's see if I can figure out where it's coming from. I see a raised hand. I'm not sure if you can help me. Go ahead. Yes, there's Sarah. Go ahead.
I was actually going to clap, but I have a question too. So I chose the wrong thing. So thank you, Renee. That was wonderful. We are in the process of forming our equity team. And I've got some neonatologists, some OBs, I've got kind of some nurses. And my question is, I have the people that I have available as a pool, and they don't necessarily all meet the ideal set of qualifications. And then I find myself in a position where I'm like, okay, do I ask folks who are more diverse than the majority of the group is several white people who have signed up? Do I ask folks if they want to join? Is that a strategy that's okay? What is a better strategy for getting people to join? Who are the right people?
I'm hearing some okay. The thing is that it's better if you can get champions that are inspired to join. Those characteristics and the right people that I shared, honestly, they're your ticket to success. But who has the ideal people all the time? Not necessarily, right? So do you have any people that have shared interest in doing this work? Okay.
Yes.
Okay, so I would grab them as champions because can have different level of people who participate in different ways. But you also have to have leaders that can help really move and shake and get you to the finish line. So you really need to have those leaders who are also um, inspired to do it. Honestly, often what I would do is ask my friends in high places. I've asked anesthesia attendings. I've asked people who are respected and that they may not volunteer to work with you, but if you ask them, they will participate. So it's not like they're waving their hands saying, yes, I want to participate, but you know who they are in your organization that are very involved in different things. They are individuals in terms of being able to think out of the box. They're aware of things happening in the organization. Those are the people that you really want to pull in as well. So you have several tiers. You have the staff, you have thought leaders, and you have administrative people that are supporting you so that you have buy-in. And then they may change as you're moving in terms of moving towards your goal. You may see others that may want to join as well, and others that no longer have the capacity to. So that will shift also. Does that help, Sarah? Okay, thank you.
It's a fantastic question. Thank you, Sarah. Are there additional questions? I actually have one for you, Renee, which is to simply just, when people take their very first step, I know for some places who just don't have an equity committee at all, and I hear you saying, ask your friends in high places, start pulling together the folks that, can come together. What do you think is one of the sort of first best tools for people to put together to create their equity goals? I think it's the map it process, or a driver diagram with change concepts. What do you think is sort of somewhat, for those who are new to QI, if their team hasn't done QI, maybe one of the better first steps?
I tell you, the 4 equity goals that we started out with, that's why we created them, to make it easier. Those are kind of the basic things that we can do in our organizations. And we could start off with creating that equity statement. What do we stand for? What are we about? And that webinar that we did together, I really gives you the roadmap, or the recipe for how to do that. And I would suggest that all of you look at those webinars, because it really is, we try to make it as practical as possible. Having been in QI for a number of years, the easier things are, the more doable it is for people to ascertain. And when we launched into the space of equity, it just felt like, how do you do this? How do you wrap your arms around this? Right? And I still feel like a lot of people feel that way. How do we do this? But one thing that I want to drive home is that get into the notion, really embrace the notion that equity is quality, quality is equity. So if we want to give good care and high quality care, it must be equitable. And going back to your question, Audra, using those initial goals to select one, and then getting a team together to decide, how do we do this here, and really thinking it through and talking it through. And plus, you have resources in Pinquin that are amazing resources, more than other states, and you have PQI. So, and we're partnering and figuring it out too. And you have a national, people nationally are working on this, other health professionals. So you're not alone. And a lot of them are facing the same barriers, and can offer some facilitators that will help you get past the challenges that you have. One of the things that we try to say in our education is, I would suggest not to, it's like a double negative. Let's not start out with a goal that says, let's meet to meet to meet. about the meeting, right? Let's get to the heart of what we need to do and try to figure it out together. But you have templates to use to start from. And I hope that the tools that I share with you will be helpful to you.
Very much so. Thank you. Go ahead.
Audra, this is Bonnie, with a hello, with a an offer, and that's and thank you, Renee. This has been absolutely marvelous. Something I've been working on for a while and accumulated a pile here in my study on the floor that's about 2 feet deep. And I've been and these resources would be consciousness raising. It would not be the elements of the plan, that would be made in the institution, but to the degree to which you would want to do consciousness raising around equity. Because I've collected a number of these things, over the years. Some of you know that I went to graduate school at the University of Mississippi, and I had an opportunity to work with some really remarkable people there. And some of these things are visuals. They're slide PowerPoints that are just visuals. I have one of Eudora Welty, if anybody remembers Eudora Welty as an author, who took pictures of African-American families in Mississippi. I've got it, and I'm almost finished with assembling this. So it's going to be a list, like a bibliography. And then all of the resources I will have available for you electronically. My husband, who's my chief operations officer, is going to scan everything so that it's available to you. But and you could use these at any point, whether you're consciousness raising to initiate the project or at some point along the way. But and there's been a lot published. I mean, a number of these references that I have are things that have been published in both the medical and nursing literature in the last 5 years or so. So at any rate, I will finish that within the week and send it to, I'll send you a copy, Renee, but I'll send to Claire and to Audra and Ron, and we can figure out how to make it available to you.
That is wonderful, Bonnie. And also, too, I encourage all of you to sign up for the 28-day challenge because, as Bonnie is saying, inspiring folks and to understand what the situation is, but also it engages you in an action, a short action, small action to do every day, as well as a learning activity that can really be engaged any time of the year. We're launching version 2 February 1st. But if you recall, you all had access to version 1. So there's a quote. This can be done during when you're meeting to start the day, during your huddle, and it raises consciousness for what we need to do in terms of providing equitable care daily. So thank you, Bonnie, for that, and I look forward to the list.
All right, it's forthcoming.
Thank you.
And just one other thing to acknowledge is that our fearless leader, Fifi Diop, who's on the call, has been recognized for her enormous contributions to equity. So we have more than a valuable resource in our leader.
I agree. Thank you. Well, thank you for that fantastic presentation, Renee. We really appreciate all that you do for us. Excited to be a part of the 28-day anti-racism challenge. I think that the activities are always really helpful and fantastic. Claire, thank you. Also, Claire Cole wrote, she highly recommends the 28-day challenge. It's helpful. And then also there was a comment from Michelle Sinopoli at St. Vincent's that their hospital didn't have a DEI committee. So instead of the department level, they started a committee at the hospital level using resources, and it's just been difficult to gain momentum, which I can completely understand. Yeah, so I really appreciate all that's happening, and I really think that even Janet added a comment to the chat. It's helpful to have the activities of 28-day challenge just as really digestible, chunked information that people can really grasp onto and move forward with. In the last 5 minutes, we have some wrap up and announcements from Kaylee, our project manager, and so I'll turn it over to her. Just want to say thank you to all the comments in the chat, and thank you for all the wonderful teaching that you gave us today, Renee.
Thank you, Audra. And yes, thank you, Renee, for that wonderful presentation steeped in QI. For anyone wondering whether equity is QI, it definitely is, as evidenced by today's wonderful webinar. So really quick, friendly reminder that our next webinar is next month on December 20th. I know that's bumping up against some of the December holidays, but we hope to still see a good many of you for our presentation on equity goals. And coming soon, we will have more information about how to claim continuing education credits for attending these webinars live or watching the recording. So keep an eye on your email for more information about that. Just a reminder that our webpage for the equity bundle is a great resource that Claire and I and Audra and everyone on our work group contribute to. There is a page to view the equity webinar archive. Claire has been putting that link in the chat along with the access password, but please email us if you need that link or password again. And also for anybody on the call who maybe did not see their hospital listed on our map of participating hospitals, there you can onboard at any time. You just need to submit a team roster and we'll make sure you're all set to submit data with the Betsy Lehman Center as well. So just click on equity onboarding when you're on our website. And just a reminder, we've gotten a couple of questions over the last month or so of just what does it mean to be part of the equity bundle? So a quick reminder of our expectations, not requirements, are to watch our monthly webinars, either live or the recordings, submit monthly data. It's really, really helpful when you can, to the best of your ability, submit data every month, just so that we can see those numbers grow and stay consistent. Have at least 2 champions. Renee mentioned in her presentation having an OB and an RN champion, but of course you can have more than 2 champions as well. Actively implement the structure and process measures that we've discussed today. And we also have coaching calls available. Coaching calls are a requirement for those 5 hospitals that are part of our CDC grant, Brockton, Lowell, MGH, St. Vincent, and Tufts. But for everybody else, they are optional and available. So just send an email to me or Claire if you're interested. And we also, just in the spirit of our collaboration with Team Birth, wanted to put a slide up here about their expectations as well. We have a great number of hospitals who are doing both the equity bundle and Team Birth, which is amazing. So since we're cutting close on time, I won't read through all of these, but they will be part of our slide deck that we'll share afterwards. Few upcoming events. Renee already plugged the free Speak Up Champions education happening in early December for Massachusetts providers. We already have 85 people registered. We'd love to see that number grow, so please register if you'll be free. And again, the 28-day anti-racism challenge. I wanted to just quickly say here, there was a comment in the chat whether this challenge is individual work or if it can be done as part of a group, and the answer is both. I think multiple members from the same team could sign up individually, and then, as was shared in the chat, one hospital team has reviewed the prompts as part of their daily huddles. So I think that's wonderful. Renee, I saw you come off mute. Do you want to say anything about that too?
No, exactly what you said, Kelly. Thank you.
This month is also Prematurity Awareness Month, so just a friendly reminder from our friends at March of Dimes, a couple of announcements here. Spread the word on your social media. We also partner with the Partners in Contraceptive Choice and Knowledge. Their fall webinar series is wrapping up. There is one tomorrow and another in December. And information to register is coming to you from Claire in the chat and is also on our website. Penguin will be having our spring summit in person on April 12th of next year at the usual place in the 4 Points Sheraton in Norwood. We'll be focusing on our equity projects, this bundle. The other part of our CDC grant is focused on social determinants of health screening in the NICU, so we'll have presentations about that. And the Penguin team is working very hard to put together an excellent agenda for everybody. So we really hope you all are able to come, and we'll be excited to share more details on registration soon. Like we've mentioned a few times throughout today's webinar, we have this existing equity webinar series that we hope you all will take advantage of and watch the recordings to help your work. And then finally, many of you were with us for the hemorrhage and hypertension bundles as well, and we have free credits available for attending or watching those recordings. These credits do have an expiration date for now. We will look into extending that, but please take advantage of this resource as soon as you can. And with that, thank you, everybody. 101, we'll see you next month for our webinar on equity goals. Thank you so much.
Thanks, everyone. Have a great afternoon.